Welcome to live Q&A with the experts of Rome Foundation. My name is Tanya Murphy, Executive Director here at Rome Foundation. Today's session is titled Diet and Nutrition with DGBI. And again, I'm your host, Tanya Murphy, along with my co-host, Doug Drossman. And I'd like to introduce him today and talk a little bit about him. He is CEO and President Emeritus of the Rome Foundation, President of Drossman Center of Education and the Practice of Biopsychosocial Care, and also Professor Emeritus of Medicine and Psychiatry at the University of North Carolina at Chapel Hill. He is the founder of the Rome Foundation and an internationally recognized scientist, clinician, and educator in DGBI and communication skills training. He is a pioneer in researching the impact of trauma and abuse in patients with IBS with the first NIH-funded study in this area. He is passionate about engaging and educating his patients to utilize self-management techniques in their recovery. Today, Dr. Drossman is joined by our Rome Foundation board member, Bill Chey. Dr. Chey is the H. Marvin Pollard Professor of Gastroenterology, Professor of Nutrition Sciences, and Chief of the Division of Gastroenterology and Hepatology at the University of Michigan School of Medicine. I now turn things over to the esteemed Dr. Drossman.
Thanks, Tanya. Boy, with those introductions, we need to have more time for our talk.
That's
Bill,
true.
it's great to see you. Bill is a member of the board of directors, and he's running the program in Michigan. I think one of the most notable things you've done is how you really moved the diet and nutrition into the mainstream of GI. I think if I could name one gastroenterologist who's done it, it's you. And I really think it's great, and it's great to have you on the Rome Foundation for that reason. And I think we'll be talking about it. You've even developed your own section in diet and nutrition with the Rome Foundation. So welcome, and I'm going to ask you a few questions. I look forward to hearing more.
Thanks, Doug. It's the pleasure is all mine. Trust me.
Well, why don't we begin? Because, you know, years and years ago, when you asked patients what do they think causes their symptoms, it came out to be diet. The fried chicken I had last night, or and then things happened with gluten, and a lot of other items got onto the media, and the science wasn't there. And I think if you look at the last decade, there's been an explosion of research looking at diet, food and diet, and IBS, and then the other DGBIs. So I think the first question is, where's this data? Why does food matter for DGBI?
Doug, food matters because patients say it matters. To the point that you originally made, for decades, patients have been telling us that food is the most important trigger for their IBS-related symptoms. And, when I started out in this specialty in gastroenterology in 1990 as a GI fellow, I was taught that diet played no role in the pathogenesis or symptom experience of patients with IBS, and that the association with food was largely driven by psychosocial overlay. But like so many examples in medicine, the patients frequently turn out to be right. And in this case, that certainly is no exception. If you really listened to your patients, they would tell you that they would eat, and soon thereafter they would develop symptoms. And that was really the initial impetus for me to get interested in this area, because I was convinced that our dogma at the time wasn't right. And it turns out it wasn't right.
Yeah, I mean, I'm thinking about 90, there was a lot of motility work going on. And the only relation to food was if you put something in your stomach, it increased your gastrocolic reflex and gave you pain and diarrhea. So we've come a long way. And I think a lot of the research now has been trying to isolate, I say using IBS examples, certain kinds of diets which may be more relevant. And why don't you tell us a little bit more about that? What are the best diets? And is there one that is for all, or can you specify?
Yeah, the short answer to that question is the one size does not fit all. But taking a step back, if you look at the history of this whole thing is the way it's evolved. Um, Really, if you think about the reason why medications were so frequently used in the 90s and really over time, it's because pharma funded large studies, phase 2, phase 3 studies that proved efficacy of those drugs in patients with DGBI like IBS. There was absolutely nobody to fund those kinds of studies for diet therapies. And in fact, I can say, having gone through this myself, is that uh, scientifically, the GI community was really tough on diet studies because diet studies are intrinsically very difficult to do. You can imagine trying to blind a diet study. What's the right duration? What's the right dose of the different types of foods that you're either eliminating or supplementing? So these studies are intrinsically very difficult to do. And for that reason, nobody did them for many, many years. Now, if you look at how quickly diet has become accepted over the last maybe 10 to 15 years, that's happened pretty quickly. And it's really happened related to the fact that all over the world, people have recognized this association between eating and developing IBS symptoms, and done outcome studies. It's amazing, actually, if you look at the body of work that supports the use of certain diet therapies. The most notable one right now is the low FODMAP diet, which happens to be the most evidence-based diet intervention for patients with IBS. There are probably 15 randomized controlled trials at this point. There's quite a bit of literature. Now, admittedly, there are methodological problems and all the studies are small. There aren't any hundreds of patients phase 3 studies like we see with medications. But the good news is for this large number of small studies, they're virtually all pointing in the same direction.
So the patients were driving the beginning of the research on that, at least in your case, and maybe others as well, and now it's taking on. Can you say more about the kinds of diets that are available?
Sure. Yeah. So again, the low FODMAP diet is the most evidence-based diet for patients with IBS. And it's really important to remember that the low FODMAP diet consists of 3 phases. It's not, I think everybody associates the low FODMAP diet with the restriction phase, where you remove the 5 different categories of FODMAPs or sugars that are very difficult for your intestine to break down and absorb, and leave it at that. But remember that you should think about the restriction phase as almost like a diagnostic test to determine whether an individual, an IBS patient, is sensitive to FODMAPs or not. And if they respond, if their symptoms improve with the restriction phase, it's critically important to go on to the second phase of the diet plan, which is reintroduction of foods containing individual FODMAPs to determine each IBS patient's individual sensitivities. And that information can be used in the third phase, personalization, where you liberalize the diet and allow patients to restrict just the FODMAPs that are driving their symptom experience. So that's the low FODMAP diet. And it's really taken off. In fact, I oftentimes half-heartedly joke and say that 15 years ago, when I first started talking about this in the United States, my job was to convince people that this was a reasonable thing to do. In 2024, I think the low FODMAP diet is probably overused. And in fact, I spend a lot of my time trying to make sure that people use the diet responsibly. For example, if somebody is exhibiting really restrictive eating behaviors, you don't want to put them on a highly restrictive diet like the low FODMAP diet. It literally could be dangerous for the patient, throwing gas on a fire, if you will. So what are some other alternatives? Well, healthy eating habits. There's something called the NICE guidelines, which have been developed by the British Dietetic Association in the UK. And these are common sense dietary recommendations for patients with IBS. Things like making sure that you have regular meals, that you have enough time to eat your meals, to drink enough fluid during the course of the day, to restrict caffeinated beverages and carbonated beverages, to restrict certain types of high fiber foods, which can be gas producing and cause bloating in some individuals. Also avoiding certain sugar alcohols like sorbitol. And it turns out, these common sense recommendations make about 40% of IBS patients better, which is quite extraordinary when you think about it. And then the last thing, which is really exciting, I think, is that there's recent data to suggest that diets that aren't based on restriction, but are more based on a healthy dietary program, like the Mediterranean diet, can also be beneficial for some groups of IBS patients as well. So I always think of it this way, is that the low FODMAP diet kicked the door open on diet therapies for patients with IBS patients. But as we walk through that doorway, we're finding that there are lots of other options, not just the low FODMAP diet. And I think that's what's most exciting about this area for me as a scientist and as a doctor in 2024, is that the world is really our oyster now in terms of looking at diet more holistically and thinking about restriction on the one hand. People are talking more about things like confocal laser endomicroscopy as a means of identifying patients with food sensitivities, or IgG antibody testing to certain foods to fashion an elimination diet for individuals with IBS symptoms. But I'm equally excited about the development or the embracing diets that actually don't restrict, but actually promote a healthy lifestyle.
So until the technology comes, as I guess one of the top doctors in this area, what goes on in your mind when a patient comes to you? How do you make a decision as to which diet to use, or when not to use a diet?
So we wrote about this in a recent AGA clinical practice update on diet in patients with irritable bowel syndrome. And the journey starts with asking a really simple question. It's going to seem like we don't even need to say this, but believe it or not, it doesn't get done a lot. We actually just did a chart review, which actually proves that a lot of times doctors don't ask their patient if their symptoms are related to eating a meal. If the symptoms aren't related to eating a meal, a diet therapy probably isn't the best way to start on that patient. And you'd be surprised how often that question gets overlooked or doesn't get asked. So just simply asking a patient about whether their symptoms are food related or not is a great way to start. If they're food related, and the patient's really motivated, I think, again, from an evidence standpoint, the low FODMAP diet is the choice that's most likely to get you to symptom resolution. That said, it's entirely reasonable to go for these NICE guidelines, these common sense dietary recommendations, as a way to step into diet therapy if the patient isn't interested in pursuing a really highly restrictive diet with 3 phases. And then finally, if somebody's already tried the low FODMAP diet, you might want to think about a trial with the Mediterranean diet. People have also talked about a very low carbohydrate diet. In fact, a guy named Doug Drossman was the first one to publish on that, and it's just recently been validated in a very large randomized controlled trial from Sweden. So a very low carbohydrate diet, which is also a restriction diet, obviously, and a gluten-free diet people have played around with as well.
What about gluten? I mean, half the patients who come to me are on gluten-free diets. They're still symptomatic, but they're on gluten. It's almost becoming a health thing. To stay healthy, eliminate gluten. What's the story with that? And
that is such an interesting story, and there's so many layers that we could talk about, in regards to the whole story around. And I'll take a step back and say not gluten, but wheat,
right?
Because remember that wheat contains gluten, the storage protein gluten, but it also contains other proteins, which potentially could cause symptoms and issues in patients, like ATIs, amylase trypsin inhibitors. And very importantly, wheat also contains poorly absorbed, non-digestible carbohydrates called fructans. In fact, wheat is the largest source of dietary fructans in the Western diet. So if you think about it, wheat can cause problems through carbohydrates, proteins, and then I'll introduce a third layer to this, and that's something called the nocebo effect. You know, people listening will all be familiar with the placebo effect, this notion that if you believe something's going to make you better, it'll make you better. But think about all of the negative attribution that's been heaped on wheat, and specifically on gluten. You know, it's almost a four-letter word in Western vernacular these days. And so people going into dietary restriction or thinking about things that they're eating in their diet, a lot of people have a very negative impression of wheat and specifically gluten. And that can color the way that they respond to restriction or reintroduction into the diet. The other thing I'll say to you, which is hot off the press, we literally just published this within the last month or so, is this notion that when we're talking about the low FODMAP diet, remember I mentioned to you there's 5 different categories of FODMAPs. Well, it turns out that all of those categories aren't equal in terms of their ability to trigger symptoms in patients with IBS. So it turns out that, like in a study that we did, a randomized reintroduction, double-blind reintroduction study where we gave individuals in a blinded way, IBS patients who had responded to the low FODMAP diet, we gave them in a blinded way individual FODMAPs to determine which FODMAPs were the ones that were most likely to trigger symptoms in patients with IBS who had gotten better on a low FODMAP diet. And our study showed that fructans and galacto-oligosaccharides were the 2 FODMAP categories that were most likely to trigger symptoms. Now, that by no means was universal. There was a lot of overlap from patient to patient. But from a Bettenmann's perspective, the 2 FODMAP categories that were most likely to trigger symptoms were fructans and galacto-oligosaccharides. Jan Tak, who's also on our board, did a very similar study and found that fructans and mannitol in his study were the two most. So we've actually developed something we call the FODMAP simple diet, which is a truncated version of the FODMAP elimination based upon the results of our research, and shown in a recent randomized controlled trial, which we presented at our national meeting in May, that this truncated FODMAP simple approach yielded very similar results to the traditional low FODMAP restriction.
So for the audience, which are the fructans? Which are the ones to avoid?
So fructans are wheat sugars. Also, onions and garlic are the 2 other big sources of dietary fructans. And, you know, I'm sure that'll come as no surprise to a lot of people listening that happen to have IBS symptoms, because IBS patients so often tell you that when they eat foods with garlic or onions, that triggers their symptoms, gas and bloating.
You know, you mentioned before the other end of the spectrum. Maybe we should talk a little bit about that, about patients who are overly restrictive. They're trying to control their symptoms in some way, and they overgeneralize, and they're coming in having lost 20, 30 pounds, still feeling symptomatic. Tell me more about that group. I think we're calling it ARFID sometimes. But how do you deal with that?
Well, it's a difficult group, and I think it's really important to make clear that some degree of picky eating, if you will, if you're an IBS patient, is not necessarily pathological. You know, in fact, it's probably an entirely appropriate response to eating food and developing symptoms. Of course, you're going to try to figure out on your own which foods are the ones that are causing your symptoms. Some patients do a pretty good job of that and are able to identify foods that they can successfully avoid to mitigate their symptoms. The concern arises when people get on this treadmill where they're constantly chasing their tail, restricting more and more and more different types of foods to the point where they're now not eating enough calories. They're consuming an unhealthful diet. Another really interesting paper that we published a few years ago showed that when you look at the habitual diets of IBS patients, most IBS patients are restricting something. Secondly, is that the majority, over 60% of the IBS patients that we carefully categorized and looked at their diets, were on very unhealthful diets before they went on any restriction, with low FODMAP or whatever. So just at baseline, their diets were very unhealthful compared to a normal, balanced, everyday diet. So it's important for clinicians to be aware that this can happen and to distinguish between what can be more appropriate food avoidance, what I call picky eating, and then where it crosses a line and moves into something like ARFID, avoidant restrictive food intake disorder, which is defined by restriction that gets to the point where you're developing signs of malnutrition, unintentional weight loss, or require a feeding tube or TPN to maintain your nutrition.
Maybe this gets us into the issue of the dietitian. When does a dietitian come in, and what is their role in this treatment plan?
The earlier, the better is what I would say. I think that particularly if you're going to use anything beyond the NICE guidelines. NICE guidelines, I think that we can do that. Docs can do that on their own and do a pretty good job. But the low FODMAP diet is a different animal. Remember what I said. There's the restriction phase followed by the reintroduction phase followed by the personalization stage. That's a lot. It's a lot, not just for the patient. That's a lot for the healthcare provider. Remember that we as physicians will typically get 15 minutes, 20 minutes, 30 minutes with a patient. The dietitian for their initial visit, at least our dietitians, get 45 minutes to an hour just to deal with diet and nutrition. So think of it as a really important way to augment whatever plan you put into play in the office. They're going to do it more thoroughly, and frankly, they're going to do it better than you or I can do within the very limited time and knowledge that we have regarding not only implementing a diet, but taking a careful dietary intake assessment and making sure that the patient is eating a healthful low FODMAP diet or a healthful, NICE guideline recommendation. So they're doing a lot more for you than just implementing a diet strategy.
Where can the gastroenterologist in practice get a dietitian? What's the best way to access?
Yeah, so there's a couple of things. This is another complicated discussion, but I think there's a couple of things to just understand. The first thing is that it takes a critical mass of gastroenterologists to be able to fill the schedule for a GI dietitian. We found from our own experience that you probably need 7 to 8 gastroenterologists to fill a dietitian, to fill their schedule completely, from a GI standpoint. Now, you could certainly use a more general dietitian and send them off somewhere to get training in GI nutrition, but realize that a general dietitian is not a GI dietitian, and they will not have the requisite knowledge to be able to help you with complex IBS, IBD, EOE, celiac patients. there is a lot to know, and this field is rapidly evolving right now, both scientifically and practically from an operational dietary standpoint. You can certainly share a GI dietitian across practices. You can find a local GI dietitian in private practice and just refer patients that way. Or again, if you have the critical mass, you can hire your own GI dietitian for your group. The final thing is that there are virtual integrated care platforms that are popping up in the real world. And there are a number of these types of companies now, which offer virtual dietitian and behavioral psychologist services.
Well, thank you for that. And it's leading into some of the work you're doing with the Rome Foundation that I want to get to. But before that, maybe it would be helpful to talk about some of the new developments, the new research therapies in IBS with diet.
Yeah, there's a lot happening in this space. So many exciting things. The things that I'm probably most excited about right now are the identification of biomarkers, which will allow us to target the right diet intervention for the right patient. Right now, for the most part, you think about like low FODMAP diet, NICE guidelines, Mediterranean diet. Basically, they're cookie cutter strategies. You have these symptoms, you think you try this diet and hopefully it works, but if it doesn't, you move on to the next one. Wouldn't it be nice to be able to do a diagnostic that would tell you either how to fashion the intervention or which intervention is going to be best for that individual patient? And there's a ton of work going on right now, looking at antibody testing, looking at microbiome, looking at the metabolome. So they're looking at certain genetic markers, so SNPs, single nucleotide polymorphisms. So there's a ton of work going on right now in terms of identifying biomarkers that will allow us to pursue a course of precision nutrition. That's super exciting. The other thing that I think is really exciting is this idea of moving away from, or not moving away from, but in addition to restriction, focusing on supplementation and specifically the identification of what I call functional foods. These are foods that actually exert physiologic effects that lead to a symptom benefit. A great example would be kiwi. We did a randomized controlled trial a number of years ago now, first one in the United States, showing that kiwi was beneficial for patients with chronic constipation. It's now been replicated by a large multi-center international study, and pretty much everybody knows about kiwi. But you think about it, if that's true for kiwi, there are probably lots of other foods that we could be leveraging as potential treatments for patients with GI disorders. So we're certainly an active hunt to identify some other potential candidates, but I think it's super exciting to think about randomized controlled trials that will be validating food as medicine. And that's coming. There's absolutely no doubt in my mind about that. And I also think it's a tremendous growth opportunity, from a business perspective.
I think there was a study that compared kiwi to prunes at one point.
That was our study.
Yeah. Well, I think what I think would be very exciting now is to move into what you're building, at your institution, but also with the Rome Foundation. And it's only been less than a year that the Rome Foundation Diet and Nutrition Interest Group has been going. Can you tell us about that and how others can benefit from it?
Yeah, so what's been apparent over the last 5 years or so as I've been traveling down this road is that more and more people have been joining. In fact, one of the people that was started down this road the same time as I was Magnus Simran at the University of Gothenburg. Magnus has done a tremendous amount of work to help us to better understand the role of food in the pathogenesis of DGBI and also in the treatment of DGBI. And over time, Magnus and myself, along with the Rome board, who's always been remarkably supportive, have become more and more interested in developing a section, a diet and nutrition section, not unlike the gastro-psych section that Lori Kiefer and Sarah Kinzinger put together. And I'm really thrilled to tell you that there's been tremendous support, not only by their own board, but also by people wanting to get involved. What we're really hoping to do is to create a professional home for people with an interest in clinical science, but also the practical management of DGBI patients through diet and nutrition. So our vision is to create this space that people can come together, develop best practice tools to help patients to be better cared for by their healthcare providers, to create a extensive listserv worldwide of professionals that are interested in diet and nutrition, to also develop a space where investigators can share best practices, talk about what they've learned from performing their own research, and help the field to progress and advance. And in fact, that sort of serves as the impetus for the 3 committees that we've put together. I also want to mention that in addition to Magnus and myself, Heidi Stoudeker from Deakin University in Australia has been absolutely instrumental in terms of helping us to get this off the ground and going. So just want to make sure we acknowledge the remarkable contributions of Heidi. And then the committees are a membership committee, which is led by Nancy Jaffe and Renee Euler. Also an education and training committee, which is led by Caroline Tuck and Stein Storsrud from Gothenburg. And then finally a research committee headed by Dr. Kevin Whalen and also by Heidi Stoudeker. So we're super excited about the possibilities. Our webpage is up, so if you go to the Rome website and click on the tab for the diet and nutrition section, you can see our vision for what we're hoping to do. You can also sign up if you want to get involved, and we'd love for people to have an interest and to join the cause. We think it's going to be an exciting ride.
You had your first meeting at DTW in May. The turnout at 7 a.m. was tremendous.
Yeah,
So
I think it shocked all of us. Yeah.
One quick question. You mentioned about the gastro-psych group, and in many ways you're modeling it after their success. I think their listserv for finding a brain-gut therapist is remarkable for practitioners. You plan to have a listserv too, so will it be possible to get a dietitian through your program if for a practitioner?
Eventually, we'd love to go down that road and try to serve as a resource to connect people with an interest on the employer and employee side. But it's going to take us a little while to get to that point.
All right. Well, thank you for this discussion. Very helpful. I'll turn it back to you, Tanya. Any further words?
Yeah, I sure do I have a couple questions for you. So that is how I control my IBS, is with food management. And over the course of a couple of years, I did the restriction and the takeaways and everything. And I love what you said about trigger foods and just really trying to know what they are. How do you think broccoli is as a trigger food, along with garlic and onion?
Yeah, some people definitely have problems with broccoli, and broccoli in particular is one where there is oftentimes a dose response. So people can tolerate a little bit of broccoli, but once they pass a certain threshold, and it's very different for different people, they can develop problems because broccoli at higher doses does contain certain FODMAPs that for some individuals can be quite bothersome, particularly in regards to those complaints of bloating and gas.
Right. And also, do you find that the way the food is prepared also has a huge difference between, a raw vegetable or a raw piece of garlic compared to, cooked well or in certain oils. Do you kind of find that that's also an issue for people?
This is an area that we really need more research on, because what happens is that not just FODMAPs, but proteins and fats, as you might imagine, change dramatically with the cooking process. And the way you cook it is also matters as well.
Mhm.
So the short answer to your question is yes. The long answer to your question is we don't really have a good understanding of just how that changes. But there's no question that ripening, like let's use the example of a banana, right?
Right.
Bananas that are green bananas, really don't contain much in the way of FODMAPs, but ripe bananas contain, the sugar converts to fructose, and can be problematic for people that are sensitive to fructose. So,
Right.
we always say, one of my favorite lines that I've repeated over and over and over again, and I don't even know how many lectures I've given on food is complicated. It really is, because food is not one thing. It's lots of different things. And depending on the ripeness, how you've cooked it, how long it's been sitting out, all those things make a difference.
Right. And for a lot of individuals, they have such, when I'm with friends or business or whatever it might be, if individuals have triggers that make people so uncomfortable and they will get very passionate about, no, I can't have that. When really, no, they can probably have that, but if it's cooked, the correct way, or it's a smaller amount, they're fine with it, but they just, again, it's such a trigger that they have to just say not at all.
Yeah, and it gets to this point, which is that, and we're all guilty of this, but it's really, you're so much more likely to get to understand things as well as you can if you have an open mind to advice that other people give you. I think when people dig their heels in, they oftentimes miss the opportunity to improve or feel better in the case of having a disease.
Right, right. Yes, exactly.
On
Yeah.
that final point, thank you.
Thank you.
Really, really appreciate you coming and being here.
Yes,
My
thank you
pleasure.
so much for your expertise. Just a great discussion. I always love talking about this topic. It's very close to me. So thank you very much, and enjoy your weekend.
Thanks. We'll see you
Take care.
guys. Bye-bye.
Bye.